Okay, imagine a device, kind of like a pacemaker, but instead of regulating your heart, it dials down chronic pain. This is a real thing, it's called spinal cord stimulation. But here's the catch, the big mystery we're diving into today. Why do these incredible, life-changing devices sometimes have to get taken out?
So first, let's get on the same page about the problem we're trying to solve here. We're talking about neuropathic pain. Now, this is not your everyday, I slept funny kind of ache. This is chronic, relentless pain that's caused by the nerves themselves being damaged. It's like having faulty wiring in your body's electrical grid, just constantly firing off pain signals for no good reason.
And this is a huge deal. We're not talking about a small group of people. Somewhere between 3 and 17% of the entire global population is dealing with this. That is, hundreds of millions of people just looking for some kind of relief.
Now, for folks who have tried everything, and I mean everything, and are still in severe pain, there's this really advanced, high-tech option. It's called spinal cord stimulation, or SCS for short. People call it a pacemaker for pain, and it's a genuine beacon of hope when nothing else has worked.
So how does this thing actually work? Well, it's pretty wild. A small device gets implanted usually in your back or buttock area, and it sends these tiny, low-level electrical pulses straight to your spinal cord. The whole idea is to interrupt the pain signals before they can even reach your brain. It's like scrambling the message so your brain just doesn't get the memo that it's supposed to be feeling pain. For so many people, it's a game changer.
But, and this is where our story really gets interesting, sometimes this amazing solution has to be removed. The device is explanted, as they call it, and the patient can find themselves right back at square one. This is the central mystery we're going to unravel today.
And we're not talking about a fringe issue here. Get this, some long-term studies have found that the risk of having the device removed over a 10-year period can be as high as 38%. That's more than 1 in 3 patients in some cases. It's a significant number.
So that leads us to the big crucial question, why? Why would a technology with so much potential fail for a substantial number of people? Is it a problem with the device itself? Is it something about the patient? Or is it something else entirely?
All right, we're going to approach this like a proper investigation. First, we'll look at the review that sparked this whole explainer. Then we'll hunt for clues in the technology itself, dig into the very complex human factor, uncover what the keys to success are, and finally figure out what this all means for the path forward.
So our guide on this journey is a huge systematic review. What that means is researchers basically acted like detectives. They sifted through more than 1,000 different scientific papers and zeroed in on 21 of the most important studies, combining all their results to give us this incredibly powerful, big-picture view of the evidence.
Okay, let's start with our first line of inquiry, the hardware. The device itself. Could the technology be part of the problem here?
And right away, some interesting patterns start to pop up. The review found higher removal rates were linked to older devices, specifically those from before 2007. The data also pointed to some conventional rechargeable systems, maybe because keeping them charged is a hassle. Even the type of stimulation frequency and the kind of electrode used seemed to matter. And one really big red flag was if a patient needed an early fix-it surgery within the first 6 months.
But technology is only ever one piece of the puzzle. Now we have to turn to the most complicated and honestly the most interesting part of this whole story, the human factor.
And here is a perfect example of just how messy this can get. Check this out. When it comes to age, the evidence completely contradicts itself. Some studies pointed to younger patients being more likely to have the device taken out, maybe because of dissatisfaction. But then, other studies pointed to older patients, perhaps because they had a harder time adapting to the tech. It just goes to show you there are no easy, simple answers here.
And this is where we find one of the most powerful connections in the entire review. The success of this physical device is deeply, profoundly tied to a patient's mental health. There's a really strong link between higher removal rates and pre-existing conditions like anxiety, depression, and PTSD. In fact, one study showed that the odds of having the device removed actually went up with every additional psychiatric diagnosis a person had. Other personal factors were also huge. Tobacco use? That was a big risk factor. Using certain anti-anxiety meds like benzodiazepines before the implant was another. But one of the biggest was chronic opioid use beforehand, especially at those higher doses. It's becoming really clear that the patient's entire health picture, their lifestyle, their history, it's all absolutely critical to the outcome.
Okay, so we've looked at a lot of the risk factors and what can go wrong. But the good news is, the investigation didn't just stop there.
It also uncovered some really vital clues about what makes this therapy work.
So let's flip the script and talk about the positives. What did the evidence tell us about the things that actually protect against device removal? What are the ingredients for a successful, long-lasting outcome with one of these devices?
It turns out several factors really seem to tip the scales towards success. Things like having a normal BMI or getting the implant for specific types of nerve pain like radiculopathy. And here's a huge one. Proactively treating mental health conditions before the surgery was linked to much better outcomes. And interestingly, even the experience level of the doctor's office mattered, with clinics doing a medium number of these procedures having lower removal rates.
All right. We've looked at the clues and the technology, we've dug into the human factor, and we've found the keys to success. So let's put all the puzzle pieces together. What does this all mean?
I love this table because it shows so clearly how the why changes over time. In those first 6 months, the reasons for removal are often things you might expect after surgery, like an infection, or the little electrodes moving out of place. But after that 6-month mark, the story changes completely. It's much more about a loss of that stimulation feeling, or the device just not providing enough pain relief anymore.
And this really gets to the core conclusion from the researchers themselves. What they're saying here is that everybody is different. Every patient and every person's experience of pain is unique. There's no one-size-fits-all answer, no magic bullet. Figuring out who's going to do well with SCS is just a really complex, multi-layered puzzle.
So if you take one thing away from all this, let it be this. The success of a pacemaker for pain is not just about how good the technology is. It's really about a deep, holistic understanding of the person. It's about careful patient selection and then wrapping that person in this comprehensive, team-based care that looks at everything, not just the physical pain, but the psychological and lifestyle factors too. And that kind of leaves us with a final, really important question to chew on. As our medical tech gets more and more incredible, maybe the biggest breakthroughs ahead of us won't just come from better wires and batteries, but from how well we understand the unique, complex, and amazing human being we're actually trying to help.